The Association of the United States Army is pleased to welcome you to AUSA's Thought Leaders Webinar Series, a webinar series featuring military leaders and contemporary military authors. Kicking off today's webinar is AUSA's President and Chief Executive Officer, General Carter Ham.
Good afternoon and welcome to the Association of the United States Army's Thought Leaders Webinar. Thanks for joining us today. We really do appreciate your support. You know, America's Army faces many challenges: COVID, modernization, maintaining readiness for an ever-increasing array of missions, and of course, the continual challenge of matching resources to those increasing missions. But at the top of the list are people. General McConville has made it very clear from his very first day as Chief of Staff that his number one priority is people. You've heard it, you've seen it, people first. There are myriad people issues confronting soldiers today, but none are quite so complex nor as serious as suicide. September is National Suicide Prevention Awareness Month, and we're honored to have joining us today to discuss suicide prevention and awareness Dr. James Helis, Director of the Army Resilience Directorate. Dr. Helis has been with us before, and we welcome him back to AUSA. For those of us joining today virtually, please take advantage of having Dr. Helis here to ask questions. You can use the Q&A tab on the right-hand side of your screen to post your questions. And after the discussion, we'll take as many of your questions as time will allow. To moderate today's discussion, AUSA is honored to welcome back Lieutenant General retired Nadja West. General West was the 44th Surgeon General of the Army and the former Commanding General of the United States Army Medical Command. In 2015, she became just the very first African-American woman in the Army's history to achieve the rank of Lieutenant General. She's the highest ranking woman to graduate from the United States Military Academy at West Point. She joins us today from West Point. She's a graduate of the George Washington School of Medicine and Health Sciences, where she completed residences in family medicine and dermatology. She's held various clinical, operational, and leadership positions throughout her more than 30-year career as a soldier. I was privileged to serve with General West in Europe. She's a soldier for life. She's the daughter of a soldier. Her brothers and sisters have served in the Army. Her husband is a soldier. She's the mother of a soldier. I don't know how you can be more of a soldier for life than Lieutenant General Nadja West. You can check out General West and Dr. Helis's bios at the handout tab on your screen. And General West, I'm honored now to turn the microphone over to you. Thank you.
Well, thank you so much, General Ham. It's always a pleasure to be able to spend some time, in any venue that you're a part of. Again, I appreciate having served with you as well, and all my time in the military. So I just want to say thank you. And as you mentioned, I am joining you here from West Point today, and have the pleasure of spending some time here with the Association of Graduates, who so kindly offered a space for me to be able to do this webinar. And interestingly, the topic of today, suicide prevention and what we can do. Just wanted to do a quick plug for the Association of Graduates, because, to borrow a Navy term, it's all hands on deck. Our HIMs grip hands with each other to reach out to those for help, asking for help, or to help someone else. And so I appreciate their efforts in this area. And as a healthcare professional, as you mentioned, as a soldier, anything that we can do to address this issue is extremely important. And so I'm really honored to be able to participate today. And I'm really honored to be able to introduce and spend some time talking with Dr. Helis. And as you mentioned, Dr. Helis is, again, another West Point graduate. Although, in our discussions previously, he mentioned that he was a superintendent, but of a different academy, of the Merchant Marine Academy. And so, rivalries in some areas, but when it matters, we're all part of one team in defending our nation. And Dr. Helis, as you mentioned, was appointed to the Senior Executive Service in July 2012, and is currently serving as the director of the Army Resilience Directorate. And that's an extremely important role that we need in this in our Army and in our nation, to help our soldiers and families. And in this capacity, establishes effective strategies, develops plans and formulates policies for continued improvement of the ARD programs. And so he also works with the Army and the Department of Defense senior leaders to develop and execute short-term strategies for long-term initiatives to satisfy changing needs in a dynamic, evolving environment, supporting our soldiers and Army families. And so, Dr. Helis, Jim, I really look forward to hearing your remarks and then having a discussion with you afterwards. And I really appreciate you taking time out of your very busy schedule to talk about suicide awareness and prevention. So I'm turning it over to you, Dr. Helis. Thanks for joining us.
Thank you, General West, and thank you for that kind introduction. And to General Ham, thank you for the introduction, and thank you for the opportunity to return to AUSA and to speak out, to speak with and have what I hope is a dialogue between General West and me, but also more importantly with the audience on this very critical topic. So thank you for being here and for hosting this during Suicide Prevention Awareness Month. To be candid, we'll start off saying that suicide is a serious problem in our Army today, and it has been for several years. Every death by suicide is a tragedy. It's a tragedy for the soldier's family. It's a tragedy for that soldier's buddies, leaders, the unit. Any death, though, is a terrible thing for a unit, but especially a death where by suicide. And so it's important that we get our arms around this problem, that we reduce suicides in the Army, because this harms soldiers, it harms units, it undermines readiness, and reducing suicide fits in with Secretary Wormuth and General McConville's themes of putting people first and making people our first priority. In this space, there are no easy wins, there are no quick wins, there are no easy solutions. Suicide is a complex phenomenon. Most suicides have multiple factors that lead into them, and we can at this point neither explain the persistent increase in suicides across the Army for the last 2 to 3 years, particularly in the active component, nor has science developed any way that we can predict who individually is at a point of contemplating death by suicide. So this is a difficult space to work in and difficult questions that we have to answer if we're going to get a reduction in suicide rates within the Army. We know the who. We know the demographics. The majority of deaths by suicide in the Army are younger soldiers, grade of E6 and below. They're men. They're typically in the combat arms. They have access to a privately owned weapon, which is used in the majority of the suicides in the Army. And they have either singly or in combination financial, relationship, professional, meaning work or potentially UCMJ related problems, or behavioral health challenges, either singly or in some combination. But that doesn't tell us the why. There are many soldiers and young people who experience financial problems, relationship challenges, and the others, but the vast majority of them do not turn to self-harm. And so while we understand the who and some of the what, we don't yet understand the why. These factors that we cited are common among soldiers, they're common among young people. And one step we're taking is we're going to begin a deep dive into the last couple of years of suicide reports to see if there is anything that we've missed, if there's something that we're not seeing. We bring in an independent set of eyes to do that, to see if there's something that we can identify in the totality of the files to tell us this is why we're seeing this slow but persistent increase in suicides, again, particularly within the active duty force. Within the Army, there's a lot of activity that works towards prevention of suicides. Since last spring, the Vice Chief of Staff of the Army has met on an almost monthly basis with senior Army commanders to discuss the challenge of suicide, to discuss the phenomenon, to examine cases of suicide, and to share best practices across the force. It is an item of top priority for the Army senior leadership. But a lot of our programs, though, are not well synchronized, and we have to do a better job of organizing ourselves to holistically address suicide prevention. The People First Task Force, which was stood up in December in the wake of the release of the Fort Hood Independent Review, is developing models and tools for holistic prevention of not just suicide, but sexual assault, sexual harassment, substance abuse, and other challenges that that face our people within the Army. We have many programs in the Army that can contribute to reducing suicide. When we talk about prevention, we're trying to move ourselves more upstream, more to the left of the boom, so to speak, in terms of the problem. We're trying to look at sources such as financial counseling, relationship counseling, parenting skills, substance abuse counseling, so that the challenges that we see that are reaching a crisis point when a soldier dies by suicide are addressed early, taken care of before it turns into a crisis. This is my squad as a key initiative in this direction. We're talking about building cohesive teams all the way down to the squad level with engaged leaders, with soldiers who look out for each other's back, who know each other, with leaders who know their soldiers and can have the difficult conversations when, hey, you're not right. Something is wrong the last couple of days. What's going on? And the leaders and the soldiers have built a climate of trust where when you get asked that question, you feel free to say, I'm having problems balancing the checkbook, or my spouse and I are not getting along well at home, so that we can then connect soldiers with the resources they need to help with these problems before they turn into crisis. That's true prevention of suicide. It's looking at the problem holistically, and it's looking at the problem far before it gets into crisis. We do conduct suicide prevention training for soldiers. It primarily focuses on intervention skills, recognizing the warning signs that someone is in crisis or under duress, and the steps they can take to ask the right questions, provide care for their buddy, and escort them, get them to the proper services that they need. But again, this is a complex problem. It has the attention of the Army's leadership at all echelons, and we're working very hard to get at it. But it is not a simple problem, and there are no simple solutions here. And I think with that, General West, I'll turn over to you to begin the conversation. Okay, I think we have a technical issue, so why don't we just go ahead and jump to the chat questions to Ms. Lawani Belcher, one of my colleagues who's here monitoring that. Okay, there's one question there about asking, what do we think of buddy checks as a method to reduce suicides? That's from Glenn Yarbrough. Glenn, that's a great question. Yeah, buddy checks are important. You know, it is checking in on your soldiers. You're going into a long weekend. What is everybody going to be doing? Where are you going? Do you have something to do? Do you have some place to go? Making sure that nobody is left disconnected. We know that social isolation is a contributing factor to death by suicide. And again, buddy checks and also leader checks are important, maintaining contact with your soldiers to make sure that they're okay, that everything is well, and that they're not left isolated and alone in the barracks.
Hi, Jim. How are you?
I'm good, Nadja. How are you?
Doing well. So as you see, there's a lot of questions that are coming in, and I appreciate the answer to the first one there. One question I have here is, you know, it says, how do
I didn't get that. Could you try again? I'm still not sure about that.
Sorry, I'm getting a feedback here. So how do the myriad of harmful factors such as financial problems, poor relationships, drugs, alcohol, sexual abuse, access to childcare, access to and stigma associated with behavioral health care, toxic work environment. I mean, they mentioned a whole lot of things, poor leadership and command climate and other conditions. You know, with all those there that contribute to suicide, can the Army really address suicide prevention in isolation, or must it do it holistically in conjunction with other factors?
Yeah, that's a great question. And the answer is we have to address it holistically. We have to look really at essentially build at the community level, at building wellness within communities, bringing strong communities where there are strong social bonds, where there are resources available for soldiers to deal with the problems that, you know, are common among young people, you know, again, with relationships and finances and so on. We have to build climates of trust and confidence so that soldiers can feel confident coming to their leaders with their problems. That there's no stigma to asking for help, that, you know, to convey that asking for help is actually a sign of strength and not one of weakness, that, hey, I've got a problem that's beyond me and I need some specialized help or professional help, and therefore, to get myself back squared away so I can be a 100% contributing member of the formation. So absolutely, we have to address it holistically, and we have to look at this upstream. And again, looking at all of these together, if we can address relationship problems, at the core, let's say a communication problem with a couple, or if we can address parenting skills, that leads that helps prevent other problems. Again, as these one set of problems that faces the family begins to mushroom into others, that you have a communication problem that can potentially result in family violence, it can result in substance abuse. So again, it is, how do you move to the left of boom? How do you move upstream? How do you address these what are frankly normal life challenges before they turn to crises? So yeah, it's a great point from the question that yes, we have to address this holistically.
Yeah, again, there's not one easy answer or one pathway that causes issues with individuals with behavioral health, and so absolutely, I echo what you're saying on that. Another question that came up with, what's the interaction between resilience and suicide prevention? I mean, how do those two mesh together? And what are some of the things? I know of course, that's what the whole purpose of your directorate is. But can you tell us a little bit more about that, please?
Sure. One of the demonstrably proven, scientifically proven strategies for reducing suicide, that for which the CDC, the Centers for Disease Control, has data that supports, is teaching people problem-solving skills, coping skills. And so the resilience program, the Army Resilience Program, the training we offer is just focused on that. It's about planning your life. It's about goal setting. It's about maintaining perspective. It's about emotional regulation. It is about problem solving and staying focused on solving a problem. So there's that connection between resilience and prevention, not only of suicide, but a lot of other undesirable behaviors of substance abuse, of family abuse. That you learn to cope with challenges as they come up in ways that solve the problem, address the problem, allow you to be a fully contributing member of your formation.
Absolutely. And another question that came up. I mean, we talked about the family members. One of our listeners has a question about family members, and so is the Army tracking family member suicide? And if so, what's the progress, or can you comment a little bit about family member suicide? How big of a problem is it, and what are some of the things being done to address that as well?
Yeah, that is a great question. We track suicides not only among soldiers, but among family members and also among Department of the Army civilians. The numbers of suicides that occur among family members are fortunately very, very, very small relative to the population. So it's very hard to talk about trends, because any small increase of 2 or 3 up or down a year is going to make it look like it's a large percentage, that you had 20% or 30 or 40% more. But the numbers themselves for family and Department of the Army suicides are so small that we can say that it is still a challenge. We still provide resources for our civilians and for our family members, the same as we do for soldiers. The training is available for Department of the Army civilians. Resilience training is available to civilians and to family members. So we have the pieces in place to support them. Fortunately, the numbers are relatively low. That it's a concern, but it's not as big a concern as the deaths by suicide of soldiers.
Yeah, and then to that end, I mean, as one of the 44th Surgeon General of the Army and Army Medicine, trying to tackle that issue and tackle the problem and providing programs and behavioral health, initiatives. What is your relationship, and how closely are you working with the Army Medical Department in getting after this?
We work very closely with the Office of the Surgeon General, and the behavioral health team there, because there's a synergy among the programs, and how do we make sure that behavioral health is available and accessible to soldiers. And I would agree that the Surgeon General has really taken an active approach to enhancing the access and availability and access to behavioral health for our soldiers and family members. Up front, the nation as a whole has a shortage of behavioral health specialists. It's a challenge not just for the Army, the military, but for the nation as a whole to have enough behavioral health specialists in a community to provide the services that are required or requested in a timely manner. The Surgeon General is looking at options in terms of hiring practices and so on to try to improve the staffing of our behavioral health positions. Some of the specific initiatives that have improved the access and availability of behavioral health are embedded behavioral health teams down at the brigade level, where you have behavioral health professionals who are in the brigade footprint so that you don't necessarily have to go to the major MTF, all the way across post to attend health. And they're in the unit area so that they can, when they're not providing direct care, they can have a pulse on a feel on what's going on within the formation. With the outbreak of COVID last year and having to take steps to protect the health of the force from the virus, the Surgeon General significantly increased the availability of telemedicine, particularly within behavioral health. And one very positive stat that we saw coming out of behavioral health is we saw more use of behavioral health, which is, I see as a positive thing, that soldiers are seeking help. And we saw fewer missed appointments when telehealth was available. Again, the simplicity of not having to go to the MTF or not having to go to the office. And, unfortunately for some people, there is, not just in the military, but in society, there's a stigma that they attach to visiting behavioral health. So if you can do telehealth, you can do that anywhere you can get on a mobile device and get into your room, or get a few minutes away to have that appointment. So we've made good strides in terms of improving the access and availability of behavioral health. We're not where we want to be yet. Honestly, we're not where we want to be yet, but we're moving in the right direction. And again, there's as you said, the Surgeon General is, General Dingell is deeply committed to this behavioral health issue.
Yeah, thanks, Jim. And I just want to double tap on that. I know Scotty and his team are doing, phenomenal things. But as you mentioned, the whole issue or the concern about stigma, when you mentioned having those individuals in the unit areas where you get to know them, where people feel more comfortable going to them, I think that's really going a long way. And as you mentioned with telehealth, I think the younger generation really is familiar with and comfortable with doing that. And as more as we can get, the more that we can get individuals seen in any way, and especially in the telehealth, where, like you said, it's less in a less threatening environment potentially and more convenient. Then I think that's also going a long way as well.
We also have to continue to work to reduce stigma. The telehealth gives you that privacy, but we need to do more to reduce stigma around behavioral health. We need to do it. A lot of that involves education of the force and concerns. If I see behavioral health, it'll have a negative impact on my career. It'll negatively affect me. And so we're trying to do a better job of pushing out information that in reality, very, 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 very few, an infinitesimally small number of individuals lose their security clearances, over a behavioral health issue, or denied an assignment just because they sought behavioral health. Seeking behavioral health in and of itself is not going to be career damaging. Just the same way as if you tear an ACL or you break a leg, and you go to the hospital and you get medical care. Yes, you can't deploy for a time. Yes, you've got to go through, physical therapy, through rehab. Okay, and I've done that myself a couple of times. But then you can get yourself well, you can get back into the formation, and you can be back at 100% green and ready to deploy and move forward. And it does not adversely affect your career. And we have to better communicate that, we need to treat behavioral health just like physical health. You can see when somebody can't walk, when they can't put the rucksack on, when they can't pick up the toolbox or manipulate the wrench. Okay, there is something physically wrong. We're going to move you. You need to go see, you need to go down at the aid station. You need to go to the MTF and get checked out. Behavioral health, people have a tendency sometimes to say, well, I can tough this out. I can try to hide this. I can try to mask this. And we need to change the mindset that, look, if you're not feeling right, if you're feeling anxiety, if you're feeling what may be symptoms of depression or other behavioral health issues, there's no difference between seeking help for that medical condition than it is seeking help for an ACL. And there's no difference between making your weekly appointments to see your behavioral health provider than there is going to your appointments to do your physical therapy after you've had the surgery to repair that ACL. And we're continuing to work to educate that. It's something that we need to continue to work on and continue to press, is to beat through the myths about the negative impact of just seeking behavioral health counseling. And also that, this is something that we need to treat as a medical issue, not as an issue of you're weak or there's a character. Behavioral health issues are medical issues.
Yeah, absolutely. I can't say it any better. It's just one of it's one of the systems of your body and your well-being as a human being, and it should be treated that way. So, as many efforts as we can to continue to push that message, I think it's really important. From the medical community, sometimes it's better to hear it from outside of the medical community, because of course they'll say, yeah, the medical community, that's what they think. But when you're hearing it from outside of the, just the medical community alone, I think it will start to get traction, and people will realize, yes, this is something that's important to realize as an issue and concern, even though you might not be able to see anything physically, as a problem. Another question came up, Jim, about how do you measure the effectiveness? I mean, we have the programs here. What are some ways that we can measure the effectiveness to make sure that what we're doing is actually having the impact that we're desiring?
That's a great question, because, we're trying to address death by suicide as we're trying to look to address sexual assault, sexual harassment, and other issues as public health issues, where you're trying to move upstream of the problem, well to the left of it on a timeline. And the difficulty is, it's hard to say, okay, by improving access to financial counseling services, we prevented Y number of suicides a year or 2 or 3 years later because these problems didn't turn into crisis. By providing relationship counseling or parenting skills, these directly led to a decline in suicides a number of years later. The same with enhanced behavioral health. It's harder in a public health scenario to draw lines between specific programs and specific outcomes. What we expect to see, and what the nation saw in 2019, when after many years of going up, suicide rates came down, that by addressing the overall wellness of the community, we will see a decline in those kinds of harmful behaviors. And again, it takes patience and it takes time to see that they're working. These kind of strategies, again, looking to the CDC, providing financial supports, teaching coping skills, providing access to healthcare, particularly to behavioral healthcare, these kind of steps over time will reduce suicide. We know that from the science. And it's very, we just have to have, you almost hate to say it this way, but the patience to apply the programs, to build the wellness in the communities, to let this sink in when we'll see effects. But it's very difficult with a public health approach to put a timeline and say, okay, within 12 months, we expect to see a 5% decrease in this kind of behavior. That's very difficult to predict. But we can say that over time, in a couple of years, we should see the rates coming down. Now, it's not that we're not doing things in the immediate term, again, providing intervention skills for soldiers and leaders so that they can identify the warning signs so that we can reduce suicides. But the broader, longer term approach is the public health approach to move the solutions upstream.
Yeah, hey, thanks, Jim. And along that line, we mentioned earlier, kind of it's an all hands on deck community effort. And there was a question that came through that asked about MCOM. So the question is, what can MCOM do to improve the community environment on an installation to battle isolation and improve the sense of connection for families and soldiers? That's a great question, I think. That is a great question, and it gets to the quality of life on installations. Do we have community level programs? Do you have community level recreation programs? Do you have community level, for our population, the young soldier population that we're concerned about? Do we have community level sports programs in which they can engage? BOSS, the better opportunities for single soldiers. We need to make sure that we are invigorating and properly resourcing those programs across the Army at all installations to provide that sense of connection for soldiers, that sense of it. We also need to look, though, also at engaged leaders. It's a key to have engaged leaders who are engaged with the soldiers and making sure that their soldiers are connected, that nobody is isolated. Again, as I said earlier, that over a long weekend or a holiday period, that nobody is staying alone in the barracks, that the leaders are caring about them and looking out for them. So it's a combination of programs,
but also building engaged leaders who have that environment of trust and confidence and are truly taking care of their soldiers.
Yeah, that's great. It's important. Again, continuous effort and continuous engagement at all levels for that. It's one of the things that the question that's come up a couple of times I've seen is, what about those transition points where, that's known. I mean, the studies have shown that transition points are points of vulnerability in anyone's life cycle, transitioning from, empty nesters, kids going to college, moving, all those different things. What about the transition from active duty for soldiers, and other service members into civilian life? I mean, how is that handoff being viewed, and what's the interaction with the VA system in trying to make sure that that's kind of a seamless transition and seamless handoff?
Yeah, you're absolutely right that transition periods are points of vulnerability because you're breaking social connections, you're taking on new life, there are new struggles and new issues. The DoD works closely with Veterans Affairs to ensure that the warm handoff occurs between soldiers and VA, that there's a better, steps to measure that, particularly for medical issues, that there is a continuity of care, that somebody does not retire and have this drop off in a gap of period where they're trying to get signed up for the VA and get into the system. So again, that's a program worked, G1 and Surgeon General on how do we make sure that we have better transition, particularly in the medical community for VA. Another transition period that we're looking at is the PCS process. Again, where you uproot your family and you move them from, coast to coast or to or from another country. And Sergeant Major of the Army has very aggressively taken on sponsorship program, got built into the budget and into the TOD, into the returning to reception companies so that there's a more robust way of welcoming our soldiers into their new and their families into their new installations to make sure that they are properly transitioned and handed off into their new unit. So again, sponsorship is a key part of that. And again, that's one that the SMA has really aggressively worked over the last year to where now we're seeing the standing up of replacement companies that aren't having to be taken out of hide with borrowed military manpower within installations, but are going to be fully staffed by the Army.
Yeah, thanks, Jim. And and a comment and a question came in that really touches my heart here, and it's of a West Point graduate who is working as a in a high. I won't say the name because I don't know if that person would like me to share it, but just the situation here where they're working for a high level official of the a civilian aide to the Secretary of the Army in a certain area, and has mentioned that they're a suicide survivor, and commented on the piece that Major General retired Greg Martin wrote on his struggle with mental illness, stigma, and suicide. And so the question here is, are there any other examples of soldiers who've struggled with and are still struggling with this? And have there been any thoughts of utilizing their experiences, of course, if they wish to share them, to kind of try to encourage and help others? And thank you for sharing that in this environment. I appreciate you bringing that up. Thank you.
Yeah, and again, for to the questioner, thank you for sharing that experience and raising that question. And General Greg Martin and I are classmates. We've served together in the past, and my heart goes out to him. Has for a while on the challenges that he's faced, but I applaud him for the courage he has to step up and talk about the problems, the behavioral health issues that he has had to wrestle with within his life. I say the short answer is yes. The Vice Chief of Staff has been, very deeply engaged in suicide prevention for, on probably a daily basis for the last year and a half. And one initiative he is looking at is identifying, and he's already identified a couple of people who are survivors of suicide, to have them go out and share their stories within the force. We're also encouraging leaders, particularly senior leaders, to share their stories of how they have had difficult times in their life and how they've had to seek out help to get them through some challenges, including behavioral health challenges. So we are encouraging people to speak up about that, and we are looking at work for our to incorporate survivors into suicide prevention training.
Yeah, thanks, Jim. And another question, there's a couple of them that kind of go together. And one of them is, are there initiatives to combine military-related efforts with other first responder organizations, such as, firefighters, law enforcement, et cetera? And is there sharing across services? So kind of combining those two, kind of sharing best practices with our fellow service members, and then also reaching out and kind of going across to other first responders. Can you comment on that, Jim?
Within the first responder community, this is common training to be prepared, to get a call that there is a potential suicide or potential death by suicide, or someone who's having suicidal ideation. So we do train for that within our law enforcement, within our EMTs, again, within our first responder community. If you arrive at a site, steps that you can take in case you encounter somebody, a suicide situation where somebody is suicidal. There's also the, what do you do if you get to a site and there's already been a death by suicide, and what do you need to do at the spot, and what attention do you need to pay to the survivors who are still there, who have just discovered their buddy to have tragically died by suicide. We do integrate with the other services. The Department of Defense has a suicide prevention office. We meet on at least once a month across all the services to share best practices and to develop common approaches to the problem. We meet at a working level called the Spark. There's a suicide prevention general officer steering committee where we share it at our level. And actually, when I get finished here, I'll be going over to the Pentagon to prepare the Vice Chief of Staff to prepare General Martin for an engagement tomorrow with the Deputy Secretary of Defense's workforce management group, which tomorrow is meeting to review the upcoming annual suicide report and talk about suicide prevention across the Department of Defense. So this is something that we engage with the other services and with OSD at all levels, from the working level up to the very senior level.
Yeah, thanks, Jim. And then there was a comment, really good comment. One of the listeners mentioned that the Commanders Ready and Resilient Council, the CR2C, is a platform that can be used to bolster those preventive programs to attack soldier or workforce problems before they turn into a crisis. So that's so the folks out there are thinking of how can we pool efforts for that. So thank you for that recommendation. And then a question, another question from a member is, how can AUSA local chapters support programs that invest in the soldiers and families who are struggling with stress and trauma? So, again, a lot of folks are wondering, how can people want to help? How can we? How can the AUSA chapters? Are there things that you can think of that they might be able to do to help?
Yeah, I'd go beyond AUSA chapters to to all of the military and veteran volunteer support organizations. Engage with the installation, try to determine what's going on with the population at the installation, and what are things that you can do to support community level activities that help build communities and help bring soldiers and bring families together. How can you help with within the transition process as soldiers arrive new to your community, so that they can get information on what are opportunities for recreation? Where can you find healthcare in the community? Particularly given that the majority of our soldiers do not live on post. Opportunities within the community, how to seek help within the community, connecting them with others in the community. I think that is the big thing that the organizations do is again, supporting community building activities and building bridges between the local community and the installation.
And there's another question about kind of the measures of things that we've been doing to see if there's any effectiveness. And I remember doing these quite a bit as well. The question is, we've been doing the CSF MRT for over 10 years. Is there any statistical evidence that it's making a difference?
No, I would sit there and say one of the challenges we have with the variety of efforts we have is we have not done an adequate job over time of assessing how well those programs are working. And just starting with the basic, are we actually implementing the programs, across the Army consistently and to standard? Are we resourcing those programs across the Army consistently and to standard. Again, we have not done a good job of assessing those programs. The anecdotal evidence we get from that is that resilience training is effective. Soldiers appreciate it. Often we get the, I wish I'd had this training in this development experiences sooner. So we have to do a better job of educating on the programs and a better job of ensuring that we are resourcing and implementing those programs and then properly assessing them.
That's great. Boy, got a lot of questions. This is generating a lot of discussion and great questions. So one of the questions that was put in the queue was, could we be, could we include more suicide awareness prevention training and leadership training courses for both officers and NCOs? And this person believes that this training could be developed and presented by behavioral health professionals, counselors, psychologists, and social workers as part of that. So any comment on that one?
Yeah, absolutely. We are working to incorporate more prevention training, not just suicide prevention, but prevention writ broadly within our leadership development programs. Recently, we've added blocks to the pre-command course at Fort Leavenworth for brigade battalion commanders and command sergeants major. The training is provided by the Sharp Academy, which is at Fort Leavenworth, by ARD, by the Resilience Division, by our staff, and by the Army Public Health Center. So that's a unified effort there to look at what are the issues that you're going to have to deal with, and how do you holistically address prevention, and how do you address prevention upstream, not just intervention, but looking upstream. Within suicide prevention, another that we're specifically doing is we're in the process of publishing the suicide prevention regulation as a standalone document now. And along with that will be commanders' handbooks for installation commanders, for senior commanders, and a second for brigade and battalion commanders that very specifically will outline details of responsibilities and techniques and ways that they can effectively implement suicide prevention programs, both at the senior commander level and down at the battalion and brigade level. So we are working to get those tools into the hands of our leaders.
And Jim, regarding compos, can you comment on any, is there one compo of our soldiers that are more vulnerable than others? I mean, are our reserve and guard soldiers at greater risk, active component, or how would you characterize that?
I would say clearly the active component is at higher risk, and we have seen the risk within the active component increasing over the past couple of years. The guard and the reserve is fairly steady, maybe declining a little bit. National Guard had concerns with the high degree of mobilizations that they went through last year between COVID, between disaster relief, between support to civil authorities, the record numbers of National Guard mobilizations, that might downstream, not in the immediate, but downstream, lead to problematic behaviors, including self-harm and suicidal behaviors. So these are steps being taken within the components to address the issues of suicide. And again, they're supported by the Army staff, by HQDA.
Yeah, well, thanks so much. And there's one comment in here that says, Dr. Helis, I'm so glad you've chosen to do this. And I want to echo that person's comments. I mean, as a healthcare professional and as a, understanding how important behavioral health is, and just to have a well-rounded, person, a human being. I mean, that's part of who you are as a person, and to be focused on this and to give it the attention that it deserves, really appreciate it. So I echo that person's comment. I'm so glad you've chosen to do this. And I'm so glad that you've chosen to spend your time today with us on this extremely important topic. And the wide range of questions that and comments that were given I think shows how important everyone else thinks this is as well. So I just want to say thank you so much for joining us today. And I'll turn things over to General Ham now.
Okay, I'm going to take a few minutes from General Ham to wrap it, but thank you for those the kind comments and the comment. It's a privilege for me to be in a position of leadership here, and it's a privilege for me to be working on these critical issues for the Army. I'm, every day I get up and say, that what we do is important. but it's not as much me as it is the outstanding team of professionals that I have with me of active duty officers, non-commissioned officers, of Department of the Army civilians, both within ARD, and then the whole team that we work with. We do a lot of work with the Army Public Health Center. We've been working with Leavenworth and CAC on pre-command courses, working at installation level on assistance visits to help better utilize the resources they have, particularly their performance centers, the resilience experts, and the commitment of the senior leadership, Secretary Warmoth, General McConville, General Martin, Sergeant Major of the Army Grinston. It's a privilege to work with that group who is, I can tell you from being in the room with them on a regular basis, are absolutely dedicated to the proposition that people are the most important thing in the Army, that we're going to put people first, and that we are going to put the resources and the effort towards eliminating suicide, sexual assault, and those other behaviors that harm soldiers and their families and disrupt cohesion and readiness. So again, thank you for the comment, but this is an all hands on deck team effort, and it's my privilege to be part of the team. And with that, thanks for moderating a great panel, the support team here, and to General Ham, and sorry to steal a couple of your minutes. Thank you all very much.
Well, thanks very much, Dr. Helis. And General West, thank you to you for moderating today's event. Thanks especially for calling out the recent article by Major General retired Greg Martin. And I encourage the audience to just search on your website, Major General retired Greg, G-R-E-G-G, Martin. It's a worthwhile article to read about mental health, to be sure. And General West, I think your focus on soldiers' stories and the discussion that you had is vitally important, because soldiers trust other soldiers, and hearing from one another is a good way to address this issue. And speaking of trust, I think Dr. Helis raised that word a number of times, trust, which is so vital. Trust between soldiers and their leaders, soldiers with their families, soldiers to soldier. That element of trust is absolutely vital in what we do. So Dr. Helis, thanks for your continued efforts in this effort. Thanks again for joining us once again here at AUSA. And I guess as I was thinking, as listening to you and General West have the discussion, as we find ourselves in football season, I think this matter of suicide is one that says, hey, that no one's on the sidelines in suicide awareness and prevention. Everybody's on the field, everybody's engaged, everybody's on the team, and everyone has a role to play. It's not somebody else's problem. It's my problem. It's your problem. It's all of our problems. And until we are all engaged, we're not going to make the progress that we would like to see. So Dr. Helis, General West, thanks again for a great event. Before we close, just a reminder of a couple of upcoming events. The AUSA annual meeting, 11 through 13 October at the Walter E. Washington Convention Center in person, 20 days from today. We look forward to seeing all of you in person at the Walter E. Washington Convention Center. It's going to be a great event. Just you can register. You should register right now at ausa.org. It's too easy to register. We've got a couple of events coming up after the annual meeting. On the 16th of November, we'll hold another Thought Leaders webinar featuring James Kitfield, the author of In the Company of Heroes, the inspiring stories of Medal of Honor recipients from America's longest wars in Afghanistan and Iraq. So our most current Medal of Honor recipients, you'll look forward to that. The day after that, on the 17th of November, a noon report on the Army's climate strategy and action plan, a matter of great importance to the Army and to our nation. To get more information on these events, to register for the AUSA annual meeting, just go to the website ausa.org and you can do all of that. Finally, to those of you who are AUSA members, thanks for your membership. It really does matter. It is your membership that allows us to put on events like this. If you're not an AUSA member yet, it's a little unfathomable to me why you would not yet be an AUSA member. But again, go to ausa.org, a couple of strokes of your keyboard, and you'll be an AUSA member. And we look forward to you joining us. Thank you all very much for a great event today. Let's have a great Army Day.